All right, so we're going to go over fluids and pharmacology. So our body is made up of 60-70% water. Here's some images that show you kind of where that fluid is located. So our intracellular fluid, or the ICF, is about 2/3 of body water. And that is fluid that is inside of our cells. And then the other third is our extracellular fluid, which makes up the 1/3 of our body water. And that consists of intravascular, so that's the plasma that's in our blood cells, and interstitial fluid, which is the fluid between our cells. So our body is mostly water, and where that water lives, it matters just as much as how much there is. So you'll hear the term fluid shifts, and that just indicates that this water is moving and that balance is getting thrown off. Okay, so it's moving to places where it doesn't normally live. And those explain edema, dehydration, shock, and will help us understand why IV fluids work the way that they do. You already know this, but everything in our body is about balance, and we know that is called homeostasis. This is maintained by osmosis, and we know that water is a chaser, so it moves from low solute concentration to high solute concentration just to dilute things out and keep everything balanced, okay? So water follows the S's, and y'all need to remember that where there is water, there is salt or sodium and sugar or glucose. So, and vice versa. Those things are water is going to follow the sugar and the salt. And so, also where fluid flows, electrolytes go. So I believe y'all already learned about lab values some. You'll get more in depth in that as you go through your adult health courses. And as you start taking care of patients. So one thing to consider is that lab values are helpful in painting a picture and relaying that to how the patient is presenting. But it is very important for you to know that sometimes lab values aren't really given a clear indication of what's going on because there is a potential for hemodilution or hemoconcentration where there's either too much water or fluid overload, such as in hemodilution, where the labs look off, they're low, okay? And then in hemoconcentration, the labs are going to be high. And so when you notice abnormalities in your patient's lab levels, consider if they've had excess fluid or if they're dehydrated or not taking in fluid, or if they're unable to excrete it or they're excreting too much. Okay, so I know is important for you to consider. Some examples of some things that could contribute to hemodilution or heart failure or renal failure, and hemoconcentration, burns, and severe dehydration. All right, so you need to know that sodium controls water movement outside the cells. Sodium is equivalent to fluid balance. So, because we said where sodium goes, water is going to follow. So you can see here in this picture, we have king potassium living inside the cell in the intracellular fluid, and queen sodium is hanging out in the extracellular fluid. So think about where, with sodium moving, if water is going to follow it, that whatever happens, it's going to swell. And you can probably think about that yourself, either from hearing other people or if you've experienced that yourself. If some people, I know I'm sensitive to this, if I take in a lot of salt or I drink a lot of salt, especially if I'm not taking in enough fluid, but even with both, um, you can get puffy, right? Like you have swelling. And so hopefully that makes sense. If you have sodium, there's going to be water, and that includes in the cell. So if sodium leaves the cell, the blood, and goes into the cell, then the cell is going to swell. So that balance can get thrown off by the VPPS. So basically, losing fluid is because the electrolytes and fluid go together, that when we lose fluid, electrolytes are also going to be lost, okay? So examples: vomiting, sweating, peeing, pooping, that includes taking medications that are influencing those. So what is a medication that can contribute to excess urination? Diuretics. So diuretics make you, or their function is to get rid of excess fluid, which you want if a person has fluid overload, but they also take electrolytes out with them. So especially loop diuretics, something called furosemide or Lasix. It's a commonly given diuretic. It's considered a wasting drug, and potassium and sodium goes with that. So while we want the fluid to go away, we then are going to end up with electrolyte imbalances. And so those are considerations when you're giving medications that are causing any of these things to occur. Another consideration are burn patients. So it is very important to consider because they are losing lots of fluid and electrolytes because their skin, that barrier that's containing all those things, is compromised. This, some of these slides in this lecture and in the electrolytes are duplicates just because I liked the way they looked and I couldn't decide which one I wanted to keep. But this is pretty much just a repeat of what was on the last slide, but this might be easier for you to look at. All right, so now we're going to talk about IV fluids. So we choose IV fluids based on what the cell needs. So for isotonic, you can think isoperfect. So it stays in the vascular space. This is as close as you can get to giving a patient blood without giving them blood, because you also can do that. But so has equal concentration as blood. So fluid stays in that intravascular space where it is being replaced. For the hypotonic, think hippo. So it goes into the cell and makes it swell because the concentration is lower than blood. In hypertonic, it is pulling the water out of the cell. So therefore, it is going to shrink the cell and make it skinny. So it's all about osmolarity, which is basically just the pulling power of the solution. So if the osmolarity is high, it means it has high pulling power. And we do use this to our advantage. So if the brain is swelling, we can give a high osmolarity fluid to pull that water out of the brain cells. So again, here's just a different picture to show you. I tried to provide options of what might be helpful for you to understand and just for reinforcement. So the ISO is equal, the hypo, those solutes are low and it's pushing the water into the cell. Hyper, those solutes are high and it's pulling the water out of the cell. All right, so in a little more detail, the first fluid we're going to talk about is isotonic solutions. So if somebody is just getting volume replacement, they are going to most likely be given normal saline. Again, these have the same concentration as blood. And this includes isotonic solutions, include normal saline and lactated ringers. They are used in trauma conditions, surgery, and rapid volume replacement. So when someone is receiving a bolus, that usually is normal saline is what is being administered, because, again, that is as close as we can get to blood to provide that replacement. And I think we talked about this the first day, but a bolus is just you are giving a very rapid fluid replacement. So normally, y'all will see this in the hospital where patients are on continuous IV infusions. They will have um, a 1 liter bag, usually, and it can be whatever fluid has been ordered. In this case, we'll say it's normal saline, and they have it at 125 milliliters an hour. And that means that every hour they are getting 125 milliliters of fluid. And usually that is because there's some sort of depletion. Maybe they're not eating or drinking as much. And just to make sure that they're getting enough intake. So in that case, if somebody was getting a continuous infusion at 125 milliliters an hour, and we check their blood pressure and it's really low, let's say that they've gone septic and their blood pressure dropped, I could bolus just that fluid. So I could get an order to give them a 1 liter bolus, or I could a 500 milliliter bolus, whatever. And all I would have to do is take that exact bag of fluid, that normal saline, change the rate from 125 milliliters an hour to 999, which means they would be getting, if I'm giving the whole liter, 1,000 milliliters in 1 hour. So what do you think is a concern with that? If I'm giving it to them too quickly, then they can develop fluid volume overload, right? Because their body isn't processing it quick enough, or isn't handling that accumulation of fluid. And so then the blood flow is going to start getting backed up. It's not pushing the way that it's supposed to, right? Who do you think is going to be most at risk for that? So heart failure patients, high blood pressure patients with high blood pressure, or renal failure patients. So if we are worried about that blood backing up and fluid getting overload, how would I know that, or what am I assessing for? We're going to listen for crackles, right? Because that could indicate that the patients have pulmonary edema. Other concerns, and I'll say for lactated ringers, in my experience, that is typically given to patients who are going to surgery. That's usually what they will be given before, during, and after surgery. It is important for you to be careful giving lactated ringers to patients who are at risk for hyperkalemia. As far as fluid volume overload, I also forgot to say we would check for jugular vein distension, as well as bounding pulses, and just the patient having shortness of breath. Okay, here's just another picture of this that might be more helpful. All right, so hypotonic, this is moving the fluid into the cells. Very important for us to never give hypotonics to patients who have increased intracranial pressure, or ICP, because it's going to make the brain swell, okay? So just remember that hypotonic is making the cells swell. It also could make the brain swell, so we would not give that to those patients. And then D5W, I'm sorry, I didn't say the medication. So hypotonic include half normal saline is typically what you think of. D5W is a little confusing because it is actually isotonic if it's laying on a shelf. But once it gets infused into the body, it eats the sugar, and leaving just water, which makes it hypotonic in the body. Okay, so it's going to have that same function once it's infused. Times when we would give this to patients are in cases of cellular dehydration, DKA, or if patients have hypernatremia, because we'll give them this and it kind of dilutes down the sodium. All right, here's another picture that could be helpful to you. We also want to make sure that we are monitoring the patient for tachycardia and hypotension. All right, here's just another little something to help you remember. Isotonic, we're given for volume replacement, and we're watching out for fluid overload. Hypotonic for cellular dehydration, and we're not given to patients who have increased ICP. Hypertonic, these are thick like mud. They pull fluid into the bloodstream. Medications in this are IV fluids are 3% saline as well as D10W. They can be given for severe hyponatremia or reducing increased intracranial pressure. Okay, so very important for you to pay attention and learn the difference between hypertonic, okay, and hypotonic. So this is an indication for this. We would give this to reduce cerebral swelling in somebody who has increased ICP. This does require a slow infusion, usually via a central line because it can be damaging to peripheral veins. Also has to be given slow because it can cause pulmonary edema if it's infused too fast. So what would that look like? How would I know that my patient has that? So usually they're going to have sudden shortness of breath. Usually that's worse when they're lying down. Do y'all remember what that's called? Orthopnea. They might have a cough. They can have pink frothy sputum. We may hear wheezing or crackles on auscultation. They may be anxious because they're having difficulty breathing. And then they could be cyanotic if it's severe. So what does that mean? They got that bluish discoloration, right? So I'd see that in their lips, in their extremities. So what would we do if that develops? My patient has flash pulmonary edema. What am I going to do? I'm going to stop the transfusion, right? Because that's what's causing the problem. I mean, I don't need help making it worse. I need to focus on them breathing before we continue. Here's you another picture. And here's just another picture. And so uh, these can be used for severe hyponatremia, for low sodium, or cerebral edema. Want to use a central line. Always, always, always use an IV pump and make sure it's infusing slowly because it can cause those fluid shifts. And we need to monitor patients closely. All right, so before I get into this specifically, I want to add that IV fluids can have additives in them. A very common additive is potassium. So we hadn't got there yet, but that's coming next. Potassium cannot be bolused. Very important to remember that. Whether it's IV push, just in a standalone IV bag, or if it is an additive in IV fluids, okay? All right, so as far as administering fluids, we want to make sure that we are always assessing lung sounds first, that we know what their vital signs are, and that we're closely monitoring those throughout, as well as their lab values, then their INO, making sure that if they have renal issues, that we are being very cautious, or, you know, saying that's contraindicated, not administering it, and they're having a discussion with the physician. As far as testing suggestions, you can pay attention to words like profound or severe. Usually that is a late, very important critical sign. And so we want to assess those patients immediately. Airway and breathing can be impacted, especially by potassium, magnesium, or fluid overload. And so if we want to assess their lung sounds during treatment, and if they develop crackles or shallow respirations or shortness of breath, we need to make sure that we are, number one, taking care of their airway, stopping that infusion if that is, the right action, and notifying the provider. Okay, and then I didn't say this before, but it is important. There are different dextrose containing solutions, which is sugar, and so you would not want to give those to patients who already have high blood sugar. Okay, and then here's just a little memory thing. Hypotonic solutions, they can cause brain swelling. Hypertonic, volume overload, and isotonic, they're going to also be risk for volume overload.